and move on to the next session, please.
Thank you, Dr. Arvind, and Dr. Nigam sir. That was a wonderful talk. Enjoyed every bit of it.
Thank you very much.
We're moving on. Is Dr. Banshi Saboo there?
Yes, I am very much there.
Sir, we're moving on to the next session. It is a Middle East Asian Diabetes Symposium. We have 3 talks on the same. One by Dr. Asma Deeb, Dr. Chandalia, and Dr. Muhammad Hussain. I request Dr. Banshi Saboo, my co-chair, to introduce this speaker and take the session forward.
Yes. So thanks, Sanjay. And we have with us Dr. Asma, a very close friend of mine. She is from Gulf. She's a clinical professor at Gulf University with the chief of pediatric endocrinology at Abu Dhabi. She's the Secretary General of Arab Society of Pediatric Endocrinology and Diabetology. She is also the chair of communication of the European Society of Pediatric Endocrinology and advisory board member of our International Society of Adolescent and Pediatric Diabetes, which is SPAD. She organized yearly postgraduate diabetes course with SPAD in 2015, and since then I know her very much. She was appointed as a clinical lecturer in pediatric endocrinology at University of Cambridge between 2001 to 2016 and obtained CCST in pediatric endocrinology. Her special interest in disorder of sexual differentiation, use of technology in management of children with diabetes and genetics of diabetes. It's aimed to ensure a high standard of care and development in the field of pediatric endocrinology and diabetes in Arab region and extending from Gulf through the Northern African countries. And now we are requesting her not only up to North Africa, up to Southeast Asia also. So over to Dr. Asma for her talk on a neonatal diabetes. Thank you. Thank you for joining.
Thank you very much, Banshi, and thank you for our colleagues for inviting me to this very important platform. We very much value our collaboration. I've been to India 5 times, and I wish this was my 6th trip after getting rid of COVID completely. I'm going to share my slides now, and I will talk about, as Banshi suggested, on neonatal diabetes. So I'm just trying to put this in a slideshow, which I hope you can see now. So we are moving completely different from the previous colleagues' talks. Type 2 diabetes and fancy oral and injectable hypoglycemic agents to pediatrics and particularly neonates and monogenic diabetes here. So when we talk about monogenic diabetes in general and neonatal diabetes specifically, there's a lot of fascinating underlying science in this area. And if we talk about the genotype or the genetics of this group of diseases, we can categorize it under 2 areas. So the deficiency of insulin release or action can be categorized under 3 main areas. They are either causes leading to beta cell dysfunction, insulin receptor defects, or autoimmunity triggering monogenicity. And if we translate these genotypes into phenotypes, all these fascinating underlying genetic causes have an equally fascinating phenotype, what we see at the bedside. In this talk, I will concentrate particularly about beta cell dysfunction and give you some examples of these interesting neonatal diabetes phenotypes. Some people might say, okay, so why bother? Neonatal diabetes or even monogenic diabetes in general is so rare. So why should we invite people to talk about it in webinars like this? Well, the thing is, or my personal belief, is that this group of diseases are well underdiagnosed. And in an area like India and an area like our Arab countries where consanguinity is higher than the rest of the world, we are certain that the incidence is far higher. And this is not a personal feeling, because when us at United Arab Emirates with colleagues from from the Kingdom of Saudi Arabia looked at this particular area, we found that the incidence of neonatal diabetes is much higher in the Middle East compared to Europe or America. why is it important? Well, it's important because we need to raise flags to clinicians who see diabetes in children and in adults. We need to ask the question, when did the diabetes start? Because majority of people having diabetes starting in the first 6 months are having monogenic diabetes and misdiagnosed as type 1 diabetes. If the patient has extra pancreatic features, it's unlikely to be type 1 diabetes. And that's particularly the case if the islet and autoantibodies are negative. Other example that you see in adult practice is mild, stable fasting hyperglycemia, which could be due to MODY, another form of monogenic diabetes. And also if we have a strong family history in patients with presumed type 1 diabetes, again, that's another flag. We always teach our junior doctors to remember that type 1 diabetes is unlikely if the islet autoantibodies are negative or if the C-peptide is still detectable after some years of diagnosis. And we always know and educate our juniors that type 2 diabetes is unlikely if the obesity was not seen and marked and if there was no consensus medicine. So time is coming very exciting for the signs of diabetes, that it's not purely insulin administration or giving oral hypoglycemic. There is a lot in terms of genetics and overlap of phenotypes as well as technology and new medications in this field. What's new in the area? There's lots happening in this field in terms of guidelines. ISPAT is our main reference. Screening strategies, they keep changing. Therapies are changing, and the concept of pharmacogenomics and pharmacogenetics is becoming very apparent in many diseases that can sure be a model of implementing pharmacogenomics. There are new causes appearing in the literature, and there are new genes that are being discovered to cause this type of disease. So I've just cut and pasted one table from ISPAT guidelines to tell you that all patients diagnosed with diabetes in the first 6 months of life, they should have genetic testing because the chance of them having monogenic diabetes is high. And if patients were diagnosed between the age of 6 months and a year of age, but they have negative antibodies, then this mandates genetic testing as well. If we talk about screening strategies, I mean, this is quite a complex area, and we as clinicians sometimes get stuck in not knowing, okay, now we're suspecting a genetic underlying cause, but we don't know what to do next, what to ask for. And there are many ways to tackle this. So we can do direct sequencing if we know the gene, if somebody in the family is already diagnosed with a specific gene defect, or nowadays with the cost being a little bit lower, people can go to next generation sequencing and look at a whole panel or a whole genomic to look at it. This was a paper published a few years ago by the Exeter group, but it can still be a very good reference talking about how improved it is, the targeted next generation. And this way of diagnosing underlying genetic diseases was also practiced in other areas. So this is a study from Norway where people looked at all negative patients within a registry or a cohort. And it was interesting because a reasonable percentage of patients who were classified as type 1 diabetes were in fact having monogenic diabetes. And the interesting part for clinicians like myself and many of you is that about a third of clinicians were not aware of this, and they did not recognize the possibility of monogenic diabetes. So perhaps this can become a routine in the future. Some of you might say this is an exaggeration. Why should we routinely screen for a rare disease? But if you think about it, what's wrong routine testing is that monogenic diabetes subtypes are clinically similar to type 1 diabetes and can be confusing, and the treatment might be different. And also, some patients who have monogenic diabetes, they do not need extensive annual tests for autoimmunity that is linked to type 1 diabetes. And some types of technologies, like MODY1, for example, there is some very nice increase small doses of oral vitamin agents. And they genetic testing is become less expensive in some parts of the world. However, you might oppose and say, well, not really, well, in this diabetes, because again, even though I'm saying it's more common, like Arab region or countries like India and other parts of Asia. But again, it remains rare by definition, and also regardless of high reduction. So some people might say that not looking, but keep it to yourself. But this is important for the audience here. That's what we start looking at hypothyroidism and hypertension. And this is attempted to see vaccine can be used for neonatal diabetes in right panel. 11 babies who were diagnosed with neonatal diabetes, people retrospectively went and retrieved their sister card data, and you can see nicely how those children have high glucose right from their sleep neonatal screening. So some people who are passionate about the area might say, why don't we include neonatal diabetes in general? Neonatal screening. But again, people might argue. I mean, a country like mine, I come from Libya originally, and until now, neonatal screening for hypothyroidism, which is far more common disease. So thinking about neonatal diabetes might not be necessary. I'm not sure about India and what neonatal screening we do, but some areas in the United Arab Emirates, we are building that 25 minutes, like addition of another 1 lakh. So, why should we consider?
Doctor, can I interrupt you? Your audio is not clear. So, I don't know if this is the mic. So, please check it once.
You can't hear me?
Yeah, we can't hear you clearly, and it's also broken.
So, no. I think the voice is clear, Sanjay.
No. I got a mail from the event people. That's all. Sorry.
Okay.
Right.
Okay. So when we talk about management, the fascinating areas that I personally see coming from this science of monogenic and neonatal diabetes is we can come up with targeted therapy. Because nowadays we hear a lot about precision medicine, personalized therapy, pharmacogenetics, and pharmacogenomics, and I'll give you a couple of examples. So this is a study that we have undertaken to look at the cause of neonatal diabetes. And we have shown clearly that what we see in the Arab region is completely different from what we Europeans see in terms of underlying conditions. And this is a very important example in pharmacogenetics, where the effect of KACC channel mutation leading to neonatal diabetes, it responds to sulfonylurea. So instead of troubling the child and the family with multiple daily injections, these children can be fixed to sulfonylurea, and they do very well. So this is a child that we have admitted in shock, severe BCA, before the 6 months of age, and the genetic diagnosis have shown that he has KACC channel mutation and weighs When we shifted her from insulin to sulfonylurea, she maintains fantastic glycemic control. She's really well and it was like a life-changing for this family. There are multiple publications that we can see in the literature about this interesting example of pharmacogenetics where KLCT channel mutation causing diabetes can be treated with sulfonylurea, even though the main defect is in insulin release. Glibenclamide, a medication that is very well known to our other colleagues. We don't know about these sulfonylureas, but we came to know about them, and particularly glibenclamide, because it has been shown to be very effective in this treatment, and so on and so forth. This is another very interesting example that I'd like to show you, which is tRNA syndrome, thiamine dysfunction megaloblastic anemia. This is another form of monogenic or neonatal diabetes, where these children present with diabetes and megaloblastic anemia. And guess what? These children improve dramatically when thiamine is used, introduced to their treatment. So this is another example of pharmacogenomics, where a single gene defect can or does respond to a single medication. And you can see here from this publication how the HbA1c goes down with thiamine. This is a very close example to my heart because I learned about a lot about this syndrome, Wolff-Rayleigh syndrome. And again, this is one form of neonatal diabetes where children present with diabetes. They have skeletal dysplasia, bone marrow suppression, and these children die. We have 7 children who died in our unit, our own PICU, because of liver failure. And we've written about it, highlighting a large cohort in the literature about the impact of liver disease. Why is that important? Is because there is a message here about considering elective liver transplant in these children because that saves lives. And this is a list of children reported in the literature who managed to survive when given elective liver transplant. The last one is a patient that I see in my clinic, and we have reported post-liver transplant experience over the last 10 years. So this is my last point in this talk, which is about new genes. What's new in the neonatal diabetes? And I will restrict that to what we say in our clinic. So this is a child. I have a child who presented with neonatal diabetes, and on investigation, he has pancreatic agenesis. We were not excited about this because pancreatic agenesis is a known cause of neonatal diabetes, and there are multiple genes who are known to cause pancreatic agenesis. However, when we send blood tests to look for those particular genes known to cause pancreatic agenesis, everything came back negative. And it took 10 years when I got a phone call from the lab in Mexico to tell me that, look, this patient tested negative to all known genes for pancreatic agenesis. But look what we found. Was this new gene, C1 mutation, which entails early pancreatic development and also cause some subtle or severe neurological development. So this is a new form of gene that cause pancreatic agenesis and lead to neonatal diabetes. What I'm trying to say, this particular example is the science within diabetes and particularly the underlying genetics is evolving, and we hear about these new genes and new therapies every day. So, ladies and gentlemen, this is my last slide, and I hope I didn't exceed my time. And I would like to say that, to summarize by saying, monogenic diabetes in general, and even neonatal diabetes in particular, are heterogeneous, and they are caused by multiple mutations. These mutations vary amongst different countries and ethnicities around the world, and it's very important to know what we should look for that we don't miss these cases. And although we say that the disease is rare, but my personal feeling is that it could well be underdiagnosed, and we need to alert our families and physicians as well as our young generation of diabetologists on their existence. Very important to diagnose neonatal diabetes, not only because of academic purposes and adding publications to our CV, but also because it has direct implications on clinical management and the welfare and quality plan of these patients. And one day we might have neonatal diabetes added to the routine screening in the pediatrics and perhaps in adult care. And if Banshi and colleagues allow me, I would like to tell you, ladies and gentlemen, and inform you about the great news that we followed colleagues in Hyderabad, India, and we managed to bring the ISCAT International Conference Annual Congress to Abu Dhabi. So that's another platform in the Middle East after you guys in India, following your first ISCAT. We are going to meet in October in Abu Dhabi, and I would love to see as many of you joining us. And thank you, everybody who submitted abstracts. I'll stop there. Thank you very much indeed.
Thank you, Asma. There was some issue related to the voice, so sorry for that, but many of them could not hear properly. But still, one very important question, Asma, which I want to ask you, that is neonatal diabetes. I have one patient whose mother was also probably monogenic diabetes, but unluckily her 18, that sequency which was negative, she was young. Her mother and her mother, so all three generations were already. Then the young child, after only 10 days or 15 days, he had developed severe hyperglycemia, which we treated with a very low dose of insulin for some period of time. And then after 15 days, her sugar had become normal. And then slowly we stopped everything. We sent her for blood sampling is being done for neonatal diabetes to be screened. That came also negative. And now my question is to you, if suppose now we want to do for one extended analysis, or if I want to send the sample to UK or some other part of the world where more sequencing can be done, is it possible now it can be done also?
Well, that's a fantastic question, Banshi. What you are describing is definitely a clear cause of neonatal diabetes. We do see sometimes neonatal diabetes to be transient, and it could be within some family intrafamilial variation. So the mother, the grandmother can have permanent diabetes, and a child could have the same gene, but it could be a transient diabetes. This looks very much like many patients that we saw with insulin gene mutations. And I don't know where you send the blood to, because insulin gene mutation is one of the commonest mutations that in any panel people will go and do it. So I would like to strongly recommend to you to send a sample to Exeter. As you know, they provide it free of charge.
I know they do the free of charge.
Yes, I mean, it's very convincing, the story, and I will put my money on this, that there will be a mutation coming up. If not in insulin gene, it could be in other gene, but it's a classical example.
Good, thank you. Sanjay, any other question you want to have? Or
I just have a question. Doctor, wonderful talk. Your idea of creating the awareness, especially in the pediatric wards, and trying to get a universal adaptation for screening for them. Now, my question was, these children, we saw follow-up of 10 or 12 years. What happens in late adulthood? Do they develop complications like type 2 diabetes or type 1 diabetes? What about the complication rates in these children?
That's a great question. Thank you very much. It all depends on the type of diabetes. The underlying genetics. Say, for example, the group with Walker-Trellison syndrome, they die.
Yeah.
I mean, the oldest reported in the literature is a 15-year-old child who was in our clinic, but he died of liver failure. So it depends. Children with KACP channel mutation, they lead a very good long life on sulfonylurea. So it's very much, it's heterogeneous, Sanjay, and it very much depends. Some forms of monogenic diabetes are induced by autoimmunity. So you see all those microvascular complications that you are talking about. But in general, the forms of neonatal diabetes caused by insulin deficiency will have very similar microvascular complications because the diabetes will be difficult to control. A1C will be high for years, so they will end up having the complications anyway. Great question, but the answer is not really specific.
Thank you very much. You cleared a lot of my doubt because it depends on the type of diabetes, and the genetic defect which they have, and so on. Thank you very much, Doctor. We enjoyed your talk. I don't think there are any questions in the chat
Yes.
box.
So thank you, Asma, but requesting all the delegates and participants who are in this meeting to join for SPAD, which is in Abu Dhabi, and that will be a great meeting. And we all will be having face-to-face meeting at Abu Dhabi.